Wiley definitely had feeding issues. He had to get a G-tube placed within the first 2 weeks of his birth. I think he was 8 days old when he got his G-tube surgery because he just, the enlarged tongue they wouldn't even let me try and breastfeed him. And they said no. They had me try and pump, and they would try to feed him. They were supposed to have a feeding specialist that would come visit him 2 times a week. She never came. I never saw her there. So we were being discharged, and they said, well, we can either let him go home with an NG tube, which there are some risks, or we could place a G tube. We weren't really given a decision. It was kind of like, or we could place a G tube, but we're placing the G tube. And we were then sent to another hospital. And the very first day there, they had a speech and a food specialist come in and just gave him a different type of nipple. They gave him like the flat Nook nipple, and he took it immediately. And from there, he just fed on that. So the G-tube and the surgery was pointless. And so now he has this huge scar for something he never needed. Okay. Why don't you say hi?
Hi, Wiley.
Say hi, I'm Wiley.
Hi, I'm Wiley.
How old are you, Wiley?
5.
5?
Yeah.
One of the most common effects of having BWS is having macroglossia. That's something that will affect a child's articulation. And we see that children develop phonemes, or they develop the sounds that they're supposed to be using in the right manner. However, they're using their tongue differently. Again, they're compensating for the tongue that's outside an oral cavity. If you weren't looking at the child acoustically, many of them will sound just fine. But when you're looking at them, and there's that with the tongue being used differently than what you would expect, that sometimes gives the perception that there is a problem. Me, as a speech pathologist, it's important in my job to decide what is actually treatable and what may be something that's going to be functionally part of their lives. It's not because something happened to your brain and all of a sudden you lost the ability or capacity to make certain sounds. It's because there's something in the hardware that's kind of interrupting what the brain would naturally want to do. It's not that you've totally lost that skill set. It's an interruption in where the airflow is moving and how you're actually moving your tongue in relation to your teeth and your jaw.
The issues that we focus on, predominantly from a plastic surgery or a craniofacial standpoint, are the macroglossia. Macroglossia is one of the hallmarks of BWS, and what macroglossia means is an enlarged tongue. So the tongue is disproportionately enlarged as compared to the rest of the face or the jaw. Now, macroglossia, or having a large tongue, can cause several issues. One of them, in very early infancy, right after birth, is breathing. So there are some babies, fortunately it's a very small subset, but there are some infants who are born and the tongue is so large that it's blocking the airway. And despite the efforts of the doctors in the birthing room or in the NICU, the baby really cannot breathe. The baby is struggling to breathe because the tongue is so large. That's a very rare percentage of cases. It does happen. And the treatment is to intubate the baby to protect the airway so that the baby can breathe. And then we can go on to manage it later. Most of the time when we see macroglossia, though, the baby has already left the hospital. The baby's on average feeding well and thriving, but they have a very large tongue. And the large tongue can cause several issues. One of the things that we hear most from families is drooling. That can be a real problem, and we often ask the question to the family, how many times do you have to change the bib, or how many times do you have to change the child's shirt in the course of a day? And we may get answers as high as 10 or 12 or 15 times a day. The families are having to change the clothing of the child because the drooling can be so excessive. Occasionally we hear things with feeding issues as well. Most of the babies use their tongue as their lower lip, so they figure it out. Sometimes, though, the babies struggle a bit. Social issues are also a concern, of course, when you have a large tongue. There is a misconception by the public that having a large tongue or a tongue that's hanging out of your mouth is in some way associated with IQ status or developmental delay. That's not true at all. The children who have Beckwith-Wiedemann syndrome have normal intelligence and typically don't have developmental delay. But there's an association that's often seen or felt by some of the public about having a large tongue and developmental delay. So there's the social issues. And last, and perhaps what's most important to us as craniofacial surgeons, is the relationship between the teeth and the jaw. So for many, many years, it was thought or it was expressed that children who had large tongues would eventually grow into their tongue. And the notion was thought that over time, if you did nothing and simply let the child grow and develop, that the large tongue would eventually fit into the mouth, that the child would either learn to keep the tongue in the mouth or that the tongue would fit into the mouth. What we've seen over the years is in some ways that's true. The tongue does fit into the mouth as the children get older, but it happens at the expense of the lower jaw. So what does that mean? Let me show you a set of dental models that explains that. So when we look here, this is a cast of dental models. This child happened to have braces, but you can see that the top teeth should fit in front of the bottom teeth. We all know that when we bite down and clench our teeth, our top teeth should come in front of our bottom teeth. In a person who has untreated macroglossia, where the large tongue sits in the mouth, over years, that tongue acts like a piston, and it's constantly moving forward, and it will bring the bottom jaw forward. So in a child with untreated macroglossia, those bottom teeth can wind up significantly in front of those top teeth, such as this. In addition, that large tongue can push the teeth open. So not only do the top teeth wind up behind the bottom teeth, but the top teeth also wind up in an open position, an open bite position as we call it. Now, when this is very mild, it can be fixed by a good orthodontist who's able to correct this with braces. But if the open bite and the cross bite are such that they are significant, like this, then you're talking jaw surgery or orthognathic surgery to correct that, which is a major operation. So what advice do we give for families who are considering tongue reduction surgery for their child, and how do we help them decide if their child needs a tongue reduction? I think a lot of that answer depends on the age that we see the child for the first evaluation. Ideally, we like to evaluate the children as young as possible, even in early infancy. And when we first see the child at that very first meeting, I ask the family several questions. We want to know about the size of the tongue. Was it big right at birth? Did it cause any problems immediately at birth? And what's happening now? Is the child drooling? Are there feeding issues? Are there breathing issues? Has the child seen a pediatric dentist? Has anyone detected that the jaw is already starting to move? We go through a whole series of questions to get an understanding about the macroglossia. We then examine the child, and perhaps that's the most important part, because when we look at the tongue, we're looking for several things. Not only do I look to see the length of the tongue, but also the width of the tongue, because we associate macroglossia with an enlarged tongue or a protruding tongue, but the tongue can also be wide as well, which leads to splaying or enlargement of the jaw in width as well. So we look for that. We look for the position of the tongue in the mouth compared to the relationship of the teeth or in a little baby of the jaws. We look to see if the tongue is protruding outside of the mouth. We look to see if there's a lot of drooling or oral hygiene issues. We try to get a general assessment of how often the tongue is inside the mouth versus outside of the mouth. Once I've done that, once I've gotten the history and we've done the examination, we have a really good sense of which children will benefit for a tongue reduction. Typically, it's those children who have a very large tongue that's always protruding out of the mouth, that sits outside of the gums or outside of the teeth, that really can be helped by tongue reduction.